What's up?
All right. Okay.
All right. What's going on?
We are back with Kordestani. Welcome.
Thanks. What's going on?
You could look a little happier to be here. Where's the smile?
Yay. It's Friday afternoon. I haven't had enough coffee. Leave me alone, woman.
Well, I would have brought you some.
No, anyways.
You know you just gotta say so.
Anyways.
Okay.
What's up?
So I heard that the big meeting happened last week.
Yeah, that's actually very true. We were all in Austin.
Okay, first of all, what is the big meeting?
Okay, I'm so sorry. The meeting is, I think is more, the name has been changed. So now the meeting is the big grouping of the American Society of Plastic Surgery. It happens once a year, different locales, different city. It tends to rotate around the country. This year was in Austin. And so it behooves everybody to kind of come in. And that means all the people who are part of the American Society of Plastic Surgery, all candidates, everybody comes in. And it's a good show of not only event surgeries, but it's also a showing of international.
Oh.
So a huge conglomerate, like I sat down, I met the Saudi contingent was there, the whole grouping of them. There was a whole bunch from Ireland, a whole bunch from England, a whole bunch from Australia.
Very
so
cool.
Everybody comes in. So it's a big meeting of actually getting to see how everybody's doing cases around the world. It's the main American meeting, but it's the meeting that everybody comes in for. That and the big cosmetic meeting that usually lands in Miami are the two big meetings for the whole world.
How was I not invited to this?
I don't know. Didn't you get the memo?
You're supposed to tell me.
But that was interesting. It rained for like 2 days, so everybody was kind of a
man.
little bit cranky about the whole thing. But otherwise, it was actually fun.
Okay, cool.
Yeah.
I love Austin.
Yeah, Austin's actually fun.
That's like one of my favorite cities.
Yeah. I mean, as much as a convention city as I mean, Austin's never a convention city. You think of convention like Chicago,
Right.
and convention like Vegas, not so much Austin. But anyways, it was interesting.
Totally.
So what's
Very
up?
cool. Okay, so what are maybe some of the big takeaways from the meeting?
Actually, that's a great point. So the grouping of the surgeons that tend to come with interesting new surgeries are always the Brazilians and the Argentinians. Why? Is because the regulatory agencies down there tend to be softer and not so strict. So if somebody comes up with a great surgery, they run with it. And they suddenly have 500 cases. Here, we're so cautious not to be the first person to do something because of all the litigation, etc. And you don't want to basically have all these problems. Next thing you know, the Brazilians like, I came up with a thing to do this with the belly button. And after my first 600 cases, I did it this way. And you're like, you've already done 600 cases? Yeah, I decided to do it last year. And then I gave it away for free. So 600 people, and this is my results. And everybody in the audience is like, oh my God.
So it's a really good, I mean, maybe...
It tends to be, some of it you're like a little cavalier and you're like, you're crazy.
Ooh.
And some of it you're like, wow, we would love to do that, but we've never had the opportunity to do that or the guts to do that. It's been not the most accepted. And then all of a sudden the Brazilians have done 600. So you're like, oh, okay, well, if they're going to have messes or problems, they would have seen it in 600. So let me adopt that.
So
they kind of...
proving grounds.
Yeah, they kind of do all the experimentation down there, and you're like, oh, okay, you know.
Nice.
So it's interesting, yeah. The Brazilians and the Argentinians, and then most of the European crowd, West world, tends to be behind the curve. The three things that I noticed, one is, again, as we're talking about, a lot more of the body lifts, a lot more of body contouring, a lot more BBL. There's a lot of discussion about safety concerns about BBL. That's one. And this has been a subject for some time.
Speaking of Brazilians.
Brazilian butt lift, exactly. Because the issue was everybody started doing it, including a significant number of non-plastic surgeons. So just because the procedure's there, everyone's like, oh I'm an aesthetic cosmetic surgeon. It doesn't mean anything. So a lot of the plastic surgeons were big focus is on safety, while a lot of the cosmetic, aesthetic, whoever kind of brands themselves, whatever, not so much. So if you look back...
Question though, I want to back up a second. So when you say non-plastic surgeon, cosmetic, aesthetic surgeon,
what's the difference?
What does that mean?
Okay, so that's actually a good point. I mean, there's always been an attempt to differentiate between plastic surgeons and non-plastic surgeons. Plastic surgeons, we go through full training in plastic surgery, head to toe body, several years, rigorous, go through the whole, board challenge process, board certification, etc. As opposed to non-plastic surgeons. So many states don't have anything that says, oh no, you can't do plastic surgery. Oh, you want to put in breast augments, you can't. So in many states, a general surgeon can do it. In states like Oklahoma, an internist can put in breast implants.
Okay.
So the rest of the world, because of all the marketing hoopla, doesn't really pay attention to that. They only say, oh, how come my breasts don't look the right way? They go, oh, they look okay. Why do you think I could give you such a great price at $1,000 versus $5,000 because you're not a plastic surgeon? I'm like, oh. People find this out only after. And I mean, I've had discussions with patients. They go, yeah, he's world famous plastic surgeon. I go, do you not realize his name is DDS? He's a dentist.
So we've got dentists putting in breasts.
Yes.
Oh my.
Actually, oral surgeons a lot of times. And for example, Oklahoma City, one of the biggest groupings of breast implants put in is done by an oral surgeon, a dentist.
Okay.
And again, it's not a dentist, it's a higher order of a dentist, it's an oral surgeon, he's an MD, but the fact of the matter is he has no training in plastic surgery.
Okay.
And all of a sudden it's okay.
Right.
So certain states, no way. Like California, no way. New York, no way. But a lot of other states, it's like a cowboy.
Doesn't have that regulation.
Yeah. So now going forward with the BBL, what happened is several years ago, there was a grouping of deaths that happened in Miami. And then looking back at it, almost all of them were by non-plastic surgeons doing a BBL.
Okay.
So what happened is they ran into that. But the onus fell on everybody. Suddenly the law came down, boom, hitting everybody. So the Plastic Surgery Society, the ASPS, the one that had a meeting, came and looked at it and put a task force together, coming up with all the physiology of how to minimize the risk. We're still in it because people are still doing tons of it, and the regulations are there, but people are getting around it. Again, the non-plastic surgeons. The plastic surgeons all stopped.
We're going to follow this.
Follow this. And the rule is to basically make sure that the BBL, the fat grafting, is put in the subcutaneous tissue. It's not in the muscle. They'll make sure that the tissue is put superficial. You can actually feel the area it's putting in. There's actually, in certain groups, there's an ultrasound monitoring to make sure.
I watched one of those.
Exactly,
that was really cool.
Exactly. So main things go that. And again, the issue is we're setting the rules, and the idea is making sure that the rules are set. Making people comply, making people follow, that's on the state.
Yeah.
We can just put in the guardrails and hope that people listen. But there was a lot of discussion about that. That was one of the main things.
So what kind of things maybe came out about how to enforce those guardrails?
Enforcement, you can't.
You can't,
Because enforcement is a legal thing. Society is not a legal challenge. The society can set the rules and then give it to the states. The state boards, those are the ones that are enforcement. The society has no enforcement. There's not a plastic surgeon with a shield. It doesn't, we can't play FBI of the boobs or the butts.
When you say task force, I have been binge watching The Blacklist, so I just start thinking.
Not that kind of task force. Let's see, so that was one of them. The second one is, there's a big push with new products in regards to internal bras.
Okay.
So what does that mean? So we do a lot of breast surgery, and one of the breast surgeries that we do often is a breast lift. So if somebody comes in who's older, doesn't want to have an implant and wants to have a breast lift, or they want a small implant, etc., and they want to get lifted a little bit. Well, we have a bunch of different operations to address that, specifically a vertical lift, and they kind of lift the breast. But over time, the breast, again, because of gravity, falls.
Right.
So based on breast reconstruction, based on reconstructing non-breast tissue and just kind of giving patients breast mounds from breast reconstruction, we had learned a lot of tricks in regards to putting stabilization inside, like an internal bra.
Okay.
So now the big push is not only to do a breast reconstruction, do it for regular non-cancer or reconstruction patients, really put in a barrier as an internal bra. So there's a bunch of new products like Galaflex, like Durazorb, like Strattice, like AlloDerm, all these, and a bunch of more different modifications, costs, different things, laxity, size, etc., for patients for internal bras. So there was a big hoopla about that because a lot of patients get the surgery and then they're disappointed 3-4 years after because the breast, again, because the gravity keeps it drops. Down. Exactly.
Now, is there any maybe additional risk by putting something additional into the breast?
That's a good question, but a lot of these things that are internal bras are not artificial, they're biologic.
Oh.
So what happens in time, they absorb, but as they're absorbing, they basically form a barrier or a scar level there, and it's sutured to your ribs.
Oh.
So basically it's part of your ribs, so the breast or the implant just sits there.
Cool.
Exactly. So there was a lot of discussion about that because the older version of like the AlloDerm, things that we use in reconstruction were prohibitively expensive because of cancer patients. They're like $10,000. Well, somebody doesn't want to do an internal bra for $10,000. So the new ones are $1,000, $1,500, $2,000. So
a lot more approachable.
Exactly, and a lot more doable. But now the question is just using it and getting the data because there's not thousands and thousands of cases. Because again, a lot of that was generated from breast reconstruction.
It's very prohibitive.
Prohibitive if in fact you translate it to a cosmetic arena.
Right.
For somebody who doesn't have cancer, because cancer and reconstruction with these was done in the cancer market, and insurance usually paid for it.
Now with the Strattice, I remember.
Well, it's Strattice. It's what is it? The Galaflex, Strattice. There's a whole bunch of them.
But I remember you had mentioned Strattice specifically in our breast implant illness episode.
Okay. I think for
like when it was like recurrent. Yes.
That's one of them. For some of the patients I use the Strattice often because I'm comfortable with it.
Okay.
And because I came over from reconstruction, Strattice is a big mainstay in reconstruction.
Gotcha.
For years. But that's because there was no other ones. It was Strattice and AlloDerm. Now we're having to have a lot of choices, and because a lot more patients are asking for it. Before it was like this. The other thing is Strattice and AlloDerm are genetic cadaveric. One is porcine pigs, one is human. And then basically one of the things we ran into because of COVID, when patients died, we couldn't recover any of the fascia. So the supply of all the stuff disappeared. I mean, we didn't have any.
Okay.
So that's one of the reasons why they came up with a lot of these other ones. Right before COVID and during the COVID times, it's like, we don't have any supply, so they came up with alternatives.
Gotcha. Are people asking for it because of maybe social media?
That's exactly it.
Okay.
Some of it is social media, some of it is because somebody had it and somebody read about it, or somebody had it, somebody saw some sort of excerpt on it. Not a lot has been put in, but there's a lot of interest and a lot of new supply. So that was the second one. And then you'd asked me about a couple of them. The other one that I can think of is Flankplasty. Okay, so
now what's a Flankplasty?
Like a flank of a human being. Well,
when you say flank, I think like my culinary skull.
No, not that.
Cut some meat.
Flank is like the side of your body here.
All right.
So one of the things that's happening is there's a lot of patients who've gone through gastric bypasses, have lost tremendous amount of weight. And then what happens is you've got a lot of truncal tissue, and then you tend to see a lot of ptosis, so drop in the buttocks complex, etc.
Okay.
So the traditional operation to address that was what's called a body lift. It's almost like a tummy tuck that goes all the way around, a 360. The problem we were running into is that once you do the 360, the flanks, the sides, never contoured very nicely. It was very boxy. So the groups in Pittsburgh came up with what's called a flankplasty. So instead of just going around, on the backside they tend to have a little bit more like an inverted V, and then that way all the tissue in the flanks gets resected, and this tends to give you a lot more of a contoured shape versus a lot more of just a box above and a box below minus all the circular tissue. This tends to now have a lot more of a contour, which looks very shapely in a female and tends to be very, accepting and or contour pervasive in a male. So on both sides, males and females, it tends to be much better as a nice contouring addition versus, going all the way around, it tends to be a lot more boxy. Okay. So that was actually really neat because when we compared the data and the contour and the patient's happiness, they were a lot happier with a much more of a contoured look versus everyone's happy when you get rid of all of that excess skin.
Right.
But the main thing is this tended to give them a much nicer look. And interestingly enough, the scars tend to hide very well because they'll be in the groove of the flanks and the side area, so it tends to hide very nicely, and it's not as prominent as you would think.
Really?
Yeah.
Because when I'm picturing it, I'm like, where does it stop in the back
Just
area?
usually about that far up.
Oh, okay, so it's not going too far.
No, it doesn't go all the way, but enough that you can get rid of all that flank and really contour it down so you get a nice shape.
Awesome.
Yeah, it's really neat.
How come people weren't doing that before? Just didn't think about it?
Maybe they didn't think about it. Maybe, I mean, you're always a reflection of your training. So I was trained traditionally in doing the circumferential, so that's the operation I do. And you sit there, and I've seen this operation before. I'm resistant, but now all the teams are getting taught, and they're doing a lot of cases, and they're seeing their success rate. So now you tend to come back towards it saying, oh, this would be kind of neat.
Start switching.
Yeah, exactly. The same reason why we rely on the Brazilians or Argentinians. Let them make the mistakes, and then we'll see. If a year or 2 years from now you come back and they still are doing this and they have good results, then we'll pick it up. Yeah, something like that. So yeah, that was my 3 takeaways. 1 is we're going to be doing a lot more internal supportive bras. 2 is BBLs are not going to go away, but we just want to make them safer.
Okay.
And then 3 was the Flankplasty.
Nice.
Yeah, it's actually pretty neat.
Awesome. All right. Well, I look forward to talking with you after next year's meeting.
Well, hopefully we'll see. And maybe next year we'll invite you. Nah, just kidding.
Yes.
Standing
invitation.
If you bring coffee.
I will always bring the coffee. You know this.
There you go. It's great to see you.
You too. Thank you.